Welcome to this series on USMLE, Immunology and Infectious Disease. Throughout these sessions, we'll focus on the most important diseases and concepts you need to know for your exams. This reference will highlight key points about various infections and immune system disorders, helping you build a strong foundation. As we go along, we'll break down complex ideas into clear, manageable parts so you can understand and remember them more easily. Let's get started with a solid overview that will guide you through the high-yield material in this topic. This presentation covers 25 key diagnoses divided into 3 important categories. First, there are 12 autoimmune diseases where the body attacks itself, organized by the type of hypersensitivity reaction involved. Then, we look at 7 primary immunodeficiencies, which are inherited problems affecting B cells, T cells, or both, compromising the immune response. Finally, there are 6 infectious and immunodiagnostic diseases, classic infections, that are recognized through specific serologic tests and immune system clues. Each condition comes with a concise identification sheet and a practice question to help reinforce your understanding. Autoimmune diseases often fit into one of 4 classic hypersensitivity types, each with distinct mechanisms and clues for identification. Type 1 hypersensitivity is immediate and involves IgE antibodies. When an allergen cross-links IgE on mast cells or basophils, these cells release their contents quickly, causing symptoms within minutes, as seen in allergic rhinitis. For type 2, antibodies like IgG or IgM bind to antigens on cell surfaces or the extracellular matrix, leading to cell damage or receptor effects. Diseases like Goodpasture syndrome, Graves' disease, and myasthenia gravis fall here, with the key sign being antibodies targeting specific surface antigens or receptors. Type 3 involves immune complexes, antigen-antibody clusters that deposit in tissues, triggering complement activation and neutrophil-driven injury, which is characteristic of conditions like lupus or serum sickness. A useful clue is low complement levels in granular deposits, seen on biopsy. Finally, type 4 hypersensitivity is delayed and T-cell mediated, without antibodies involved. Sensitized T-cells cause tissue damage over days, typical in diseases like celiac disease, multiple sclerosis, or acute graft rejection, and this is suggested by a lymphocytic infiltrate on biopsy and a slower onset of symptoms. Recognizing these patterns helps us classify and understand autoimmune diseases more clearly. The pattern of infections a patient experiences can help pinpoint which part of the immune system is defective. For example, problems with B cells or antibodies often show up as recurrent bacterial infections, especially those caused by encapsulated organisms, and these usually start either in infancy, like in X-linked agammaglobulinemia, or in adulthood, as seen in common variable immunodeficiency. If the issue lies with T cells, patients tend to have repeated viral and fungal infections, and a key clue is the absence of the thymic shadow on imaging. Live vaccines are also unsafe in these cases, such as in DiGeorge syndrome. When both B and T cells are affected, severe infections appear from birth, with failure to thrive, and the absence of both cell types, which is characteristic of severe combined immunodeficiency. Finally, defects involving combined immune dysfunction, along with signaling or cytoskeletal problems, show specific features like high levels of IgM due to class switch failure, or symptoms like eczema and low platelet counts, as seen in hyper-IgM syndrome and Wiskott-Aldrich syndrome. By looking at when infections begin and what types of organisms are involved, we can localize the immune defect more accurately. This slide lists several key autoimmune diseases, each involving the immune system mistakenly attacking the body's own tissues. Goodpasture syndrome targets the lungs and kidneys, leading to bleeding and kidney damage. Hashimoto's thyroiditis and Graves' disease both affect the thyroid but in opposite ways. Hashimoto's causes hypothyroidism, while Graves' leads to hyperthyroidism. Systemic lupus erythematosus, or lupus, is a systemic condition affecting multiple organs with diverse symptoms. Sjogren's syndrome primarily impacts moisture-producing glands, causing dryness in the eyes and mouth. Celiac disease is an autoimmune reaction to gluten that damages the small intestine. Myasthenia gravis causes muscle weakness by blocking communication between nerves and muscles. Multiple sclerosis involves immune attacks on the nervous system, leading to impaired nerve signaling. Allergic rhinitis is included here as a classic example of a type 1 hypersensitivity reaction involving IgE antibodies. Serum sickness is a type 3 hypersensitivity reaction caused by immune complexes. Acute graft rejection is a cellular immune response against transplanted tissue. Finally, APECED, or APS1, results from ARI gene deficiency, leading to multiple autoimmune problems due to failure in self-tolerance. Understanding these diseases helps clarify how different aspects of immune dysfunction can cause a wide range of clinical presentations. Goodpasture syndrome is identified by a combination of coughing up blood and seeing blood in the urine. It progresses quickly, causing severe kidney inflammation called rapidly progressive glomerulonephritis, along with bleeding in the lungs. It tends to affect young men more commonly. The key to recognizing it is the presence of antiglomerular basement membrane antibodies, which attack collagen IV in the basement membranes of both the lungs and kidneys. This immune response is a type 2 hypersensitivity reaction, where antibodies directly destroy tissue. The best way to diagnose it is through an anti-GBM antibody test and a kidney biopsy, which shows a distinctive linear pattern of IgG deposits along the basement membrane under immunofluorescence. This pattern of lung and kidney involvement, combined with the antibody presence and biopsy findings, confirms Goodpasture syndrome. This 24-year-old man's symptoms of hemoptysis and dark urine, combined with an elevated creatinine and a renal biopsy showing linear IgG deposits along the glomerular basement membrane, point directly to Goodpasture syndrome. This condition is an autoimmune disease where antibodies attack the basement membranes in both the lungs and kidneys, causing bleeding and kidney damage. The key finding here is the linear pattern of IgG on immunofluorescence, which differentiates it from other diseases, like granulomatosis with polyangiitis, which shows no immune deposits but has granulomas and positive C. ANCA, or IgA nephropathy, which presents with granular mesangial deposits and typically does not affect the lungs. Post-streptococcal glomerulonephritis follows a recent strep infection and shows low complement levels with subepithelial humps, while Alport syndrome is a genetic defect in collagen IV resulting mainly in hematuria and hearing loss, not antibody-mediated damage. Thus, the most fitting diagnosis here is Goodpasture syndrome. Hashimoto's thyroiditis typically presents as a painless, rubbery goiter that enlarges slowly over time. Patients may experience a brief phase of hyperthyroidism early on, which then progresses to hypothyroidism. It's the most common cause of hypothyroidism in regions where iodine intake is sufficient. Clinically, if you see a painless goiter, along with the presence of antithyroid peroxidase antibodies, known as anti-TPO, this strongly suggests Hashimoto's. The immune response involves a combination of type 2 hypersensitivity, where antibodies target thyroid cells, and type 4 hypersensitivity, which involves cytotoxic T cells causing destruction. To confirm the diagnosis, testing for anti-TPO antibody levels is the preferred method, as these antibodies are key markers of the disease. A 45-year-old woman has symptoms of fatigue, weight gain, and cold intolerance developing over 6 months, and her exam shows a diffusely enlarged, non-tender rubbery thyroid. The lab tests indicate an elevated TSH with low free T4, which points to hypothyroidism. In this scenario, the most specific antibody to check for is antithyroid peroxidase, or anti-TPO. This antibody is characteristic of Hashimoto's thyroiditis, the most common cause of hypothyroidism in iodine-sufficient areas. The painless goiter and hypothyroid symptoms match this diagnosis. In contrast, anti-TSH receptor antibodies are seen in Graves' disease, which causes hyperthyroidism. Other antibodies like anti-dsDNA, anti-centromere, and anti-mitochondrial antibodies are associated with lupus, limited scleroderma, and primary biliary cholangitis, respectively, and don't fit with this clinical picture. So antithyroid peroxidase antibodies are the hallmark finding here. Graves' disease typically presents with symptoms such as heat intolerance, unexplained weight loss, tremors, and anxiety. On examination, you might notice a diffuse goiter that feels like it's moving when swallowing, along with characteristic features like exophthalmos and pertibial myxedema. Lab tests usually show a low TSH level and elevated T3 and T4 levels. There's also a known genetic link with HLA-B8. The combination of exophthalmos and an enlarged thyroid gland with hyperthyroidism strongly points toward Graves' disease. The key antibody involved is the thyroid-stimulating immunoglobulin, or TSI, which acts like an anti-TSH receptor antibody. This triggers a type 2 hypersensitivity immune response, where instead of destroying cells, the antibody stimulates the thyroid, leading to hormone overproduction. For diagnosis, testing for TSI, or anti-TSH receptor antibodies, is the preferred method, as it confirms the presence of this stimulating autoantibody. This patient's symptoms of palpitations, heat intolerance, weight loss despite increased appetite, and bilateral eye bulging, along with a diffuse, non-tender goiter that has a bruit and lid lag, point towards Graves' disease. The key underlying cause here is an antibody that stimulates the TSH receptor, leading to excessive thyroid hormone production and the associated hyperthyroid symptoms. This immune response is a type 2 hypersensitivity, where the antibody acts as an agonist, unlike blocking antibodies that cause hypothyroidism. The eye findings and diffuse goiter are classic for Graves', setting it apart from other thyroid conditions like Hashimoto's thyroiditis, which involves cytotoxic T-cell destruction and leads to hypothyroidism, or a toxic adenoma, which is typically a solitary nodule without eye involvement. Iodine-induced thyroiditis would not present this way either, so the best explanation here is a stimulating antibody targeting the TSH receptor. Systemic lupus erythematosus typically presents with a photosensitive malar rash, often called a butterfly rash, along with oral ulcers, joint pain, and fatigue. It can also involve inflammation of serous membranes, like in the lungs or heart, and sometimes affect the kidneys or central nervous system. This disease is most common in young women, especially those of African descent. To identify it, the presence of a malar rash combined with a positive anti-nuclear antibody, ANA test, is a strong indicator, and it should be confirmed with more specific tests for anti-double-stranded DNA or anti-Smith antibodies. The underlying immune mechanism involves type 3 hypersensitivity, where immune complexes deposit in tissues causing damage. The diagnostic approach begins with an ANA screening, followed by confirmation with anti-dsDNA and anti-Smith antibody tests, which are the most specific markers for lupus. A young woman with a photosensitive malar rash, oral ulcers, joint pain, positive ANA, and signs of kidney involvement like proteinuria and red cell casts is likely experiencing systemic lupus erythematosus. To confirm this diagnosis, the anti-Smith antibody is the most specific marker. While ANA is very sensitive for lupus, anti-Smith and anti-dsDNA antibodies provide greater specificity, with anti-dsDNA also correlating with renal disease activity. Other antibodies listed, like antihistone, are more indicative of drug-induced lupus. Anti-centromere is linked to CRESS syndrome. Rheumatoid factor is nonspecific and associated with rheumatoid arthritis. And anti-Jo1 is relevant for polymyositis or dermatomyositis. This lab finding helps differentiate lupus from other autoimmune diseases with overlapping symptoms, ensuring an accurate diagnosis and appropriate treatment plan. Sjogren's syndrome is identified primarily by dryness in both the mouth and eyes, with symptoms like dry mouth, known as xerostomia, and dry, gritty eyes, referred to as keratoconjunctivitis sicca. Patients often experience fatigue, and you may notice enlargement of the parotid glands. Additionally, there is an increased risk of developing B-cell lymphomas, specifically malt lymphoma. A key diagnostic clue is the combination of dry eyes, dry mouth, and the presence of anti-RO antibodies. Speaking of antibodies, the main markers to look for are anti-RO SSA and sometimes anti-LA SSB. The immune mechanism involves type 3 and IV hypersensitivity reactions, leading to lymphocytic infiltration of exocrine glands, which explains the dryness symptoms. To confirm the diagnosis, testing for anti-RO/SA antibodies is critical, and the Schirmer test helps evaluate tear production in the eyes, further supporting the diagnosis. A 52-year-old woman with dry eyes and difficulty swallowing dry food for a year suggests Sjogren's syndrome, characterized by decreased saliva and tear production along with parotid gland enlargement. The antibody most associated with this condition is anti-RO, also called anti-SSA. This antibody is important because it can cross the placenta and, if present during pregnancy, increase the risk of congenital heart block in the newborn, a serious complication linked to neonatal lupus. Other antibodies listed here belong to different autoimmune diseases. Anti-Smith is specific for lupus, anti-centromere for limited scleroderma, anti-SCL70 for diffuse scleroderma, and anti-U1-RNP for mixed connective tissue disease. Recognizing anti-RO/SSA helps not only with diagnosis, but also with managing pregnancy risks in affected women. Celiac disease often presents with chronic digestive symptoms like diarrhea, bloating, fatigue, and weight loss or failure to thrive. A distinctive skin finding called dermatitis herpetiformis shows up as itchy, blistering vesicles and is a helpful clue. A biopsy of the duodenum typically reveals villus atrophy and crypt hyperplasia, which are key histological signs. When you combine the biopsy findings with the presence of anti-tissue transglutaminase IgA antibodies and clinical symptoms that worsen with gluten intake, the diagnosis points strongly to celiac disease. The underlying immune mechanism involves a type 4 hypersensitivity reaction, where T cells mediate mucosal damage, and it's closely linked to HLA-DQ2 or HLA-DQ8 haplotypes. For diagnosis, testing for anti-TTG IgA antibodies in the blood, followed by a duodenal biopsy, is the preferred approach to confirm the disease. This case describes a young girl with chronic diarrhea, abdominal bloating, failure to thrive, and a characteristic itchy, blistering rash on her elbows known as dermatitis herpetiformis. Her symptoms improve when gluten is removed from her diet, which points strongly to celiac disease. The hallmark duodenal biopsy findings in celiac disease include villus atrophy, crypt hyperplasia, and an increased number of intraepithelial lymphocytes. These changes reflect the immune-mediated injury caused by gluten. Diagnosing celiac disease is supported by the presence of antibodies like anti-tissue transglutaminase IgA. Other biopsy findings like non-caseating granulomas would suggest Crohn's disease. Crypt abscesses with pseudopolyps indicate ulcerative colitis, and PAS-positive foamy macrophages are characteristic of Whipple disease. The normal villus architecture would not fit this clinical picture since damage to the villi is a key feature here. Myasthenia gravis is characterized by fatigable weakness, meaning muscle strength worsens as the day goes on and improves with rest. Common symptoms include drooping eyelids or ptosis, double vision, difficulty swallowing, and sometimes weakness in respiratory muscles. It's often linked with thymoma or thymic hyperplasia. A classic feature is ptosis that gets worse with activity but improves when the person rests. The key antibody to look for is the anti-acetylcholine receptor antibody. The immune system targets these receptors through a type 2 hypersensitivity reaction, where it blocks or internalizes the receptors without directly killing the cells. For diagnosis, we rely on detecting the anti-AChR antibody in the blood, the edrophonium test, which temporarily improves muscle strength, and repetitive nerve stimulation studies that show a characteristic decline in muscle response. The patient's symptoms of double vision, drooping eyelids that worsen throughout the day, and difficulty chewing toward the end of meals point toward fatigable weakness, which is characteristic of myasthenia gravis. The chest CT showing an anterior mediastinal mass supports the diagnosis, as thymomas are often associated with this condition. The underlying cause is an autoimmune process where antibodies block the postsynaptic acetylcholine receptors at the neuromuscular junction, preventing normal muscle contraction. This distinguishes it from other neuromuscular disorders like Lambert-Eaton syndrome, which involves antibodies against presynaptic calcium channels and typically improves with activity, or diseases with peripheral nerve demyelination and anterior horn cell destruction. Myasthenia gravis features weakening muscles that improve with rest because the antibodies impair signal transmission at the receptor level. Multiple sclerosis typically presents with relapsing and remitting neurological symptoms such as numbness, tingling, and weakness. You might also see signs like optic neuritis, which affects vision, internuclear ophthalmoplegia impacting eye movement, or the Lermite sign, a sensation of electric shocks down the spine with neck flexion. This disease commonly affects young women and is characterized by symptoms that appear in different parts of the nervous system at different times. The diagnosis is supported by MRI findings showing periventricular plaques in the brain and the presence of oligoclonal bands in the cerebrospinal fluid. The underlying immune mechanism involves a type 4 hypersensitivity reaction, where T cells mediate demyelination of the central nervous system's white matter. For diagnosis, an MRI combined with cerebrospinal fluid analysis for oligoclonal bands remains the test of choice. This patient's symptoms of episodes of blurry vision in one eye and tingling in the legs that resolve over weeks, combined with multiple periventricular white matter plaques on MRI and oligoclonal IgG bands in the cerebrospinal fluid, point toward multiple sclerosis. This is a disease where the immune system attacks the myelin sheath in the central nervous system. The myelin in the CNS is produced by oligodendrocytes, so the damage here is to CNS myelin, not peripheral nervous system myelin, which is produced by Schwann cells. The presence of these plaques and the pattern of symptoms fit with a relapsing remitting demyelinating disease caused by T-cell-mediated damage specifically targeting oligodendrocytes. Other options like damage to anterior horn motor neurons or the neuromuscular junction relate to different diseases like ALS, polio, or myasthenia gravis, while dorsal root ganglia aren't involved in this presentation. Allergic rhinitis is a common example of a type 1 hypersensitivity reaction. It's identified by symptoms like sneezing, itchy or watery eyes, and a runny nose that occur soon after exposure to allergens, such as pollen, dust mites, or pet dander. Sometimes wheezing can happen too, and the symptoms might appear seasonally or year-round, depending on the allergen. The immune response involves an immediate reaction where specific IgE antibodies bind to mast cells and basophils, leading to their degranulation and release of inflammatory mediators. To confirm the diagnosis, allergen skin prick testing or measuring specific IgE levels using a RAS test is preferred. This helps pinpoint the triggers and guides appropriate management. This patient's symptoms of sneezing, clear nasal discharge, and itchy, watery eyes occurring quickly after exposure to pollen are classic for a type 1 hypersensitivity reaction. This immediate response happens because allergens cross-link IgE antibodies that are bound to mast cells via their Fc epsilon receptors. This cross-linking triggers the mast cells to release histamine and other mediators, causing the rapid onset of allergic symptoms. Other hypersensitivity types differ in timing and mechanism. Type 2 involves antibody-mediated complement activation against cells. Type 3 involves immune complex deposition, and Type 4 is a delayed T-cell-mediated response. So in this case, the immediate symptoms are driven by allergen-induced cross-linking of IgE on mast cells. Serum sickness typically develops about 1 to 2 weeks after exposure to a foreign serum, antivenom, or certain drugs. The main signs to look for include fever, a rash, and joint pain. Sometimes patients may also have urticaria or swollen lymph nodes. This condition is caused by immune complexes that form and deposit in tissues, which is an example of a type 3 hypersensitivity reaction. These immune complexes trigger inflammation, but the illness resolves on its own as the complex is clear from the body. Diagnostic testing focuses on checking complement levels, especially C3 and C4, which are typically decreased during serum sickness. Clinically, the timing of symptoms after exposure, combined with low complement levels, helps confirm the diagnosis. This patient's symptoms of fever, rash, and joint pain occurring about 10 days after receiving antivenom point to serum sickness, a type 3 hypersensitivity reaction. This happens when antigen-antibody complexes form and deposit in small blood vessels, triggering complement activation and inflammation. The low levels of complement components C3 and C4 reflect their consumption during this process. This pattern distinguishes it from other hypersensitivity types. For example, IgE cross-linking causing immediate allergic reactions, antibody-mediated cell destruction in type 2, or T-cell-driven granuloma seen in type 4. Recognizing the timing and the involvement of immune complexes helps identify the underlying mechanism as immune complex deposition activating complement. Acute cellular graft rejection typically occurs weeks after a transplant when the host's T cells identify donor MHC molecules as foreign through a process called allorecognition. This triggers an immune response where T cells infiltrate the transplanted tissue, causing damage that can be seen on biopsy as lymphocytic infiltration with tubulitis. Since there isn't a specific antibody marker for this type of rejection, diagnosis relies heavily on histologic examination. The underlying immune mechanism is a type 4 hypersensitivity reaction, meaning it is T-cell mediated cytotoxicity rather than antibody-driven. The best diagnostic test to confirm acute cellular rejection is a biopsy of the transplanted tissue, showing these characteristic lymphocyte patterns. Together, these findings help distinguish acute cellular rejection from other forms of transplant complications. A 50-year-old man with a kidney transplant who develops fever, reduced urine output, and tenderness over the graft after 3 weeks is likely experiencing acute cellular rejection. This is confirmed by a biopsy showing a dense lymphocytic infiltrate and tubulitis. The key immune mechanism here involves the recipient's cytotoxic T cells recognizing donor MHC antigens, which triggers a targeted T-cell mediated attack on the transplanted tissue. This type 4 hypersensitivity reaction typically occurs weeks post-transplant. It's important to differentiate this from other types of rejection. Hyperacute rejection happens immediately due to preformed recipient antibodies. Antibody-mediated rejection involves immune complex deposition. IgE-mediated reactions cause allergy-like responses. And graft versus host disease involves donor T cells attacking the recipient's tissues, which is not the case here. Understanding this mechanism helps guide appropriate treatment to prevent graft loss. APECED, also known as APS1, is characterized by multiple endocrine problems, with hypoparathyroidism being a common feature. It often presents in childhood and is inherited in an autosomal recessive pattern. Key clinical signs include chronic mucocutaneous candidiasis, pernicious anemia, and corneal keratopathy. The classic triad to recognize this condition is candidiasis, hypoparathyroidism, and adrenal failure. On the immune side, this disease results from defective central tolerance due to mutations in the AIRE gene, which normally helps mediate self-antigen expression in medullary thymic epithelial cells to eliminate self-reactive T cells. Diagnosis is supported by identifying specific antibodies like anti-GAD65 and antiparietal cell antibodies. Genetic testing for AIRE mutations combined with the clinical triad remains the best approach for confirming the diagnosis. This child's symptoms, recurrent oral thrush that doesn't respond well to treatment, along with muscle cramps and tingling from low calcium and hypoparathyroidism, point toward an autoimmune syndrome affecting multiple glands. Genetic testing shows a mutation in a gene important for thymic self-antigen expression, which controls immune tolerance. The AIRE gene, located in medullary thymic epithelial cells, is responsible here. Mutations in AIRE lead to a failure in eliminating self-reactive T cells during development, causing autoimmune polyendocrine syndrome type 1, or APECED, which typically combines chronic mucocutaneous candidiasis, hypoparathyroidism, and adrenal insufficiency. This gene defect is distinct from other immunodeficiencies, like IPEX, caused by FOXP3 mutations, Wiskott-Aldrich from WUS gene defects, X-linked agammaglobulinemia linked to BTK mutations, and hyper-IgM syndrome from CD40L abnormalities. Recognizing this genetic basis helps explain the presenting features and directs appropriate diagnosis and management. Primary immunodeficiencies are inherited disorders that affect the function of B cells, T cells, or both, leading to increased susceptibility to infections. There are 7 key diagnoses to be aware of. Severe combined immunodeficiency, or SCID, involves defects in both B and T cell function and is typically severe from infancy. DiGeorge syndrome results from a developmental defect in the thymus, causing deficient T cells and characteristic facial features. X-linked agammaglobulinemia, also known as Bruton's, is marked by absent B cells and leads to low antibody levels. Common variable immunodeficiency, or CVID, presents later in life with recurrent infections due to impaired antibody production. Hyper-IgM syndrome involves an inability to class-switch antibodies properly, leading to high IgM and low other immunoglobulins. Wiskott-Aldrich syndrome includes immune deficiency, eczema, and low platelet counts. Finally, selective IgA deficiency is the most common and often asymptomatic but can cause recurrent mucosal infections. Understanding these conditions helps guide diagnosis and management in patients with unusual or recurrent infections. Severe combined immunodeficiency, or SCID, typically presents in early infancy with severe recurrent infections and failure to thrive. Newborns with SCID usually cannot receive live vaccines like BCG because their immune systems can't handle them. It's often seen in children born to consanguineous parents due to inherited genetic defects. Without early bone marrow transplant, SCID is usually fatal. The key sign in an infant is recurrent infections, alongside an absence or very low levels of both B and T cells, which we can confirm with lymphocyte flow cytometry testing for CD3 and CD19 markers. This immunodeficiency involves a combined defect affecting both B and T cells, often due to mutations like IL-2 receptor gamma chain or ADA deficiency. Newborn screening with T-cell receptor excision circle, TREC analysis, is also a critical diagnostic tool to identify SCID early. This infant shows classic signs of severe combined immunodeficiency, or SCID, which is characterized by a lack of both T cells and B cells, leading to severe infections like pneumonia, oral candidiasis, and chronic diarrhea from early infancy. along with failure to thrive. The fact that the parents are first cousins increases the likelihood of a genetic cause for this condition. Management must focus on correcting the underlying immune defect, and the only curative treatment is hematopoietic stem cell transplantation. Live attenuated vaccines are dangerous here and should be avoided because the patient's immune system can't handle them. IVIG and antibiotics can help control infections temporarily, but don't replace the missing immune cells. Thymus transplantation is only effective in certain types of T-cell immunodeficiencies like DiGeorge syndrome, which does not affect B cells as SCID does. Early stem cell transplant is crucial to improving survival in SCID patients. DiGeorge syndrome is characterized by recurrent viral and fungal infections, typically linked to congenital heart defects and low calcium levels. It's often remembered by the mnemonic catch-22, cardiac defects, abnormal facial features, thymic aplasia, cleft palate, and hypocalcemia, all related to a deletion on chromosome 22q11.2. On chest imaging, you would notice an absent thymic shadow, which combined with hypocalcemia and heart defects strongly suggests DiGeorge syndrome. The key immune marker is a low count of CD3-positive T cells, while B cells and immunoglobulins usually remain normal. This condition stems from a developmental defect of the thymus due to abnormal formation of the third and fourth pharyngeal pouches, affecting only the T cell arm of the immune system. The best way to confirm diagnosis is through chest imaging to check for thymic absence, blood tests for T cell counts, and genetic testing using FISH to detect the 22q11.2 deletion. This newborn shows classic signs of DiGeorge syndrome, including a cleft palate, low-set ears, seizures from low calcium due to absent parathyroids, and a conotruncal heart defect seen on echocardiogram. The chest X-ray revealing an absent thymic shadow confirms thymic aplasia, which leads to a deficiency in T cells. Because of this T cell immunodeficiency, the patient is most vulnerable to infections caused by viruses and fungi. This contrasts with infections from encapsulated bacteria, which typically occur in humoral immune deficiencies involving B cells or antibodies. Understanding these distinctions helps direct appropriate clinical care and infection prevention strategies for patients with DiGeorge syndrome. X-linked agammaglobulinemia, also known as Bruton's, typically presents with recurrent bacterial infections starting around 6 months of age, which is when maternal antibodies decline. These boys often have absent tonsils and lymph nodes due to a lack of germinal centers, and the condition affects only males because it is linked to the X chromosome. The key marker for diagnosis is an undetectable number of B cells, specifically CD19 negative cells, along with low levels of all immunoglobulin classes, while T cell numbers remain normal. The underlying immune problem is a block in B cell maturation caused by a mutation in the BTK gene, which prevents pre-B cells from developing into mature B cells. The best diagnostic approach involves measuring B cell counts through flow cytometry and checking immunoglobulin levels, with genetic testing for BTK mutations to confirm the diagnosis. In summary, a boy with recurrent bacterial infections after 6 months, no B cells, and absent tonsils is likely to have XLA. A 9-month-old boy with repeated bacterial infections such as otitis media and pneumococcal pneumonia, along with absent tonsils and no CD19-positive B cells on flow cytometry, points to a diagnosis of X-linked agammaglobulinemia. This condition is caused by mutations in the BTK gene, which disrupt B cell development and lead to very low or absent B cells, while T cell numbers remain normal. The timing of infection starting after 6 months corresponds to the loss of maternal antibodies, which normally protect infants early on. Other primary immunodeficiencies have distinct features. AIR mutations cause APECED, WAS mutations lead to Wiskott-Aldrich syndrome, CD40L mutations cause hyper-IgM syndrome, and RAG1/2 mutations result in SCID variants. In this case, the absence of B cells and normal T cells, combined with the clinical picture in a boy, makes a BTK mutation the most likely cause. Common variable immunodeficiency, or CVID, typically presents in adults with recurrent infections of the sinuses and lungs. Unlike X-linked agammaglobulinemia, the onset is later, and patients have normal numbers of B cells. But these cells don't produce enough antibodies, especially IgG and IgA. This leads to symptoms like recurrent respiratory infections, along with an increased risk for autoimmune diseases and lymphoma. The underlying problem is a defect in antibody production due to impaired maturation of plasma cells. When diagnosing CVID, measuring quantitative immunoglobulins is key, since patients will show low levels of immunoglobulins despite a normal count of B cells. This combination of recurrent infections, low immunoglobulin levels, and normal B cell numbers points strongly towards CVID. This patient's history of recurrent sinus infections and pneumonia over 2 years, combined with low IgG and IgA levels but normal B cell numbers, points towards common variable immunodeficiency, or CVID. This condition typically presents in adulthood and is characterized by a failure of B cells to mature into plasma cells, which are responsible for producing antibodies. This contrasts with X-linked agammaglobulinemia, where there is an early block in B cell development resulting in very low or absent B cells. Other immunodeficiencies to consider include chronic granulomatous disease, marked by defective neutrophil oxidative burst, hyper-IgM syndrome, which involves faulty CD40L interactions, leading to normal or high IgM but low IgG and IgA, and complement deficiencies like C3 deficiency, which predispose to recurrent pyogenic infections but have a different immunologic profile. Here, the key feature is the presence of normal B-cell counts but low immunoglobulins, reflecting the impaired ability of B cells to become antibody-producing plasma cells in CVID. Hyper-IgM syndrome is characterized by recurrent infections because the immune system can't properly switch antibody classes. Patients typically have high levels of IgM but low levels of IgG, IgA, and IgE. This happens due to a defect in CD40 ligand on activated T cells, which normally signals B cells to switch antibody types. Without this signal, there's a failure in antibody class switching. This also leads to susceptibility to opportunistic infections, like pneumocystis, which rely on T cell help for defense. When you see a patient, especially a boy, with high IgM and both recurrent pyogenic and opportunistic infections, think of a CD40L defect causing hyper-IgM syndrome. The best diagnostic test is a flow cytometry assay to check CD40L expression, alongside measuring immunoglobulin levels. This boy's recurrent sinopulmonary infections and pneumocystis jirovecii pneumonia, combined with lab results showing high IgM but very low IgG and IgA, point to a problem with antibody class switching. The most likely cause is a defect in the CD40 ligand on activated T cells, which is necessary for helping B cells switch from producing IgM to other antibody types. Without this interaction, the immune system can't produce enough of the other antibody classes, leading to susceptibility to infections like pneumocystis. Other options don't fit as well. BTK mutations cause X-linked gamma-globulinemia with absent B cells, not just high IgM. Defects in the IL-2 receptor gamma chain cause severe combined immunodeficiency. NADPH oxidase defects cause chronic granulomatous disease, which affects phagocyte function, and AIRE defects lead to autoimmune issues but don't explain this antibody pattern. So the key feature here is the impaired T cell help due to CD40 ligand deficiency. Wiskart-Aldrich syndrome is identified by a classic triad of symptoms: eczema, recurrent infections, and easy bruising or bleeding due to thrombocytopenia characterized by abnormally small platelets. This disorder is X-linked, so it primarily affects boys. When you see a boy with eczema, small platelets causing thrombocytopenia, and frequent infections, Wiskart-Aldrich syndrome should be high on your differential. Immunoglobulin levels in these patients typically show low IgM, along with elevated IgE and IgA. The underlying immune problem arises from a mutation in the WUS gene, which impairs cytoskeletal signaling in hematopoietic cells, disrupting normal immune function and platelet formation. For diagnosis, checking the platelet count and size is crucial, as well as performing an immunoglobulin panel to confirm the antibody abnormalities. An 18-month-old boy with eczema, easy bruising, and recurrent ear infections who has low platelet count with small platelets and immunoglobulin changes, low IgM and high IgE, fits the classic presentation of Wiskart-Aldrich syndrome. This condition results from a mutation in the WUS gene, which impairs the reorganization of the actin cytoskeleton in hematopoietic cells. This cytoskeletal defect disrupts platelet formation and immune cell function, causing the characteristic symptoms. This is different from other immunodeficiencies, such as hyper-IgM syndrome, where the problem lies in antibody class switching, or chronic granulomatous disease, which involves defective oxidative burst in neutrophils. Defects in the complement membrane attack complex predispose to infections with Neisseria, and abnormalities in VIA-DJ recombination lead to severe combined immunodeficiency, but neither matches this clinical picture, as well as Wiskart-Aldrich syndrome. Selective IgA deficiency is the most common primary immunodeficiency, and it usually presents with recurrent infections in the sinopulmonary tract or gastrointestinal system. These infections tend to be mild, or sometimes even asymptomatic. A key clinical clue is a history of anaphylaxis triggered by blood transfusions, which occurs because patients develop anti-IgA antibodies. The fundamental immune problem here is an isolated defect in the production or class switching of IgA antibodies, while IgG and IgM levels remain normal. To diagnose this condition, the best test is measuring quantitative serum IgA, which will show low or absent IgA levels. When you see a patient with mild recurrent infections alongside a history of allergic reactions to blood products, selective IgA deficiency should be strongly considered. This patient's recurrent mild sinus infections and occasional loose stools suggest ongoing mucosal infections, which fit with selective IgA deficiency, the most common primary immunodeficiency. The sudden anaphylaxis after a blood transfusion is a classic clue. It happens because the patient's immune system has developed antibodies against IgA, which are present in donor blood, causing a severe allergic reaction. In selective IgA deficiency, you would see low or absent serum IgA, but normal levels of IgG and IgM. This differentiates it from other immunodeficiencies, like X-linked gamma-globulinemia, which has absent B cells, hyper-IgM syndrome, showing elevated IgM with low IgG, DeGeorge syndrome, characterized by absent T cells, and complement deficiencies, which often show low C3 and C4 levels. So the key lab finding here is low serum IgA, with normal IgG and IgM. These 6 conditions illustrate how infections or immune responses help us diagnose different diseases. Multiple myeloma is a cancer of plasma cells causing abnormal antibody production. HIV and AIDS disrupt the immune system, leading to characteristic infections and immune deficiencies. Measles is a viral infection that also produces specific immune markers. Syphilis, a bacterial infection, can be identified through serologic tests that reveal antibodies. Lepromatous leprosy represents a disseminated bacterial infection with a distinctive immune response profile. Finally, Epstein-Barr virus causes infectious mononucleosis, which is diagnosed by looking for atypical lymphocytes and specific antibodies in the blood. Each disease highlights how serology and immune clues work together to confirm the diagnosis. Multiple myeloma is a cancer of plasma cells that typically affects older adults. It often presents with bone pain, and on imaging it shows osteolytic or punched-out lesions in the bones. The CRAB acronym helps us remember key clinical features: hypercalcemia, renal injury, anemia, and bone lesions. On a blood smear, you might notice rouleau formation, which looks like stacks of red blood cells. The diagnosis is supported by finding a monoclonal spike, or M-spike, on serum protein electrophoresis, along with Bence-Jones protein in the urine. This monoclonal protein is a sharp spike in the gamma region. The disease arises from a clonal expansion of malignant plasma cells. The best diagnostic approach combines serum protein electrophoresis, followed by immunofixation electrophoresis to identify the monoclonal protein, and a bone marrow biopsy showing more than 10% plasma cells confirms the diagnosis. When you see bone pain with an M-spike and Bence-Jones proteinuria, multiple myeloma should be high on your list. This case shows classic signs of multiple myeloma, including bone pain, anemia, elevated calcium, kidney problems, and those punched-out lesions on the skull seen on X-ray. The sharp spike in the gamma region on the serum protein electrophoresis points to a monoclonal protein, or M-spike. To confirm the diagnosis, a bone marrow biopsy is needed to show that more than 10% of the marrow cells are clonal plasma cells. The other options don't fit here. A heterophile antibody test is for infectious mononucleosis. A low CD4 count suggests advanced HIV. Atypical lymphocytes indicate EBV infection, and an elevated ESR alone isn't specific enough. So the key to confirming multiple myeloma is finding the abnormal plasma cells in the bone marrow. HIV infection often presents with chronic fatigue and generalized lymphadenopathy, along with various opportunistic infections that take advantage of weakened immunity. Over several years without treatment, there is a progressive decline in CD4 plus T-cell counts. When the CD4 count drops below 200, patients become susceptible to AIDS-defining illnesses like pneumocystis pneumonia, CMV retinitis, and toxoplasmosis. If someone has an opportunistic infection and a low CD4 count, HIV/AIDS should be suspected, and diagnosis is confirmed using a combo ELISA test that detects both antigen and antibody. Key markers include the presence of anti-HIV antibodies, the decline in CD4 plus T cells, and measuring HIV RNA viral load. The immune system is compromised primarily because HIV directly infects and depletes CD4 plus T cells, which are crucial in coordinating immune responses. For diagnosis, the preferred approach is a fourth-generation antigen/antibody combo ELISA screen, followed by a confirmatory differentiation assay and viral load measurement by PCR to assess the level of active infection. A patient with prolonged fatigue, unintended weight loss, and widespread lymph node enlargement, combined with a history of unprotected sex with multiple partners, raises concern for HIV infection. When a screening test like a fourth-generation antigen/antibody ELISA is positive, the next step is to perform a confirmatory test, specifically an HIV differentiation assay or Western blot, to establish a definitive diagnosis. Simply repeating the initial screening test is not helpful because it does not increase specificity. CD4 counts are useful to assess the stage of disease and immune status, but do not confirm infection on their own. Tests like the monospot, which detects Epstein-Barr virus, or a skin biopsy, are unrelated in this context. Therefore, confirming HIV infection requires a specific differentiation assay after an initial positive screen before proceeding with staging or treatment decisions. Measles presents with the classic triad of cough, coryza, and conjunctivitis accompanied by fever. Before the characteristic rash appears, you can spot complex spots inside the buccal mucosa, which look like tiny white or bluish spots on a red background. The rash itself is maculopapular and typically starts on the face, then spreads down to the trunk and extremities, mostly affecting unvaccinated children. When you see the combination of the 3 C's, complex spots, and a rash spreading from the head downward, you can be confident it's measles. The infection is caused by a paramyxovirus, and the immune response is primarily humoral. To confirm diagnosis, the key antibody to test for is measles-specific IgM, indicating an acute infection. The diagnostic test of choice is an IgM capture ELISA, and PCR can be used to confirm the diagnosis. An unvaccinated child with fever, cough, runny nose, and red eyes who then develops tiny white spots inside the cheeks, known as Koplik spots, followed by a rash starting on the face and spreading downward, is showing classic signs of measles. To confirm this diagnosis, we rely on laboratory testing for measles-specific IgM antibodies using a capture ELISA test. This test detects the immune response specific to measles virus and is the standard diagnostic method. Other options, like the heterophile antibody test, look for Epstein-Barr virus infection. The Zank smear diagnoses herpes infections. Anti-dsDNA antibodies relate to autoimmune diseases like lupus. And cold agglutinins are associated with mycoplasma pneumonia. Therefore, the presence of measles-specific IgM confirms a recent measles infection in this clinical picture. Syphilis is caused by the Spirochaete treponema pallidum and progresses through distinct stages. The primary stage is marked by a painless chancre, a sore at the site of infection. If untreated, it advances to the secondary stage, where you often see a rash on the palms and soles, along with condyloma lata, which are moist wart-like lesions. The tertiary stage can involve serious complications like gummas, which are granulomatous lesions, as well as neurological and cardiovascular disease. If a pregnant mother is untreated, the infection can be passed to the baby, resulting in congenital syphilis. When screening for syphilis, the initial step is to use non-treponemal tests like RPR or VDRL, which detect reagent antibodies. To confirm the diagnosis, treponemal tests such as FTA-AFS or TPPA are used, which detect antibodies specific to T. pallidum and remain positive for life. The immune response mainly involves antibodies formed against the infection, helping in both diagnoses and tracking the disorder. The key pattern to remember is the progression: painless chancre, followed by a rash on palms and soles, and later development of gummas, which helps differentiate it from other diseases. This patient's history and symptoms are classic for secondary syphilis. The painless genital ulcer he had 6 weeks ago was likely a primary chancre, which then resolved on its own. The current diffuse maculopapular rash involving the palms and soles, along with the wart-like perianal lesions called condyloma lata, point to secondary syphilis. The reactive RPR test confirms there is a non-treponemal antibody response, but these tests can sometimes give false positives. To definitively confirm the diagnosis, a treponemal-specific antibody test like the FTA-ABS is needed. This test remains positive for life and is more specific for treponema pallidum infection. Dark-field microscopy is useful in the primary stage, especially to visualize spirochetes directly from the chancre, but it's not helpful at this secondary stage. Other tests listed, like the heterophile antibody, or ANA, do not relate to syphilis diagnosis, so the best next step after a positive RPR here is to perform the FTA-ABS. Lepromatous leprosy can be identified by numerous flat and numb skin lesions that are spread all over the body in a symmetric pattern. In more advanced cases, patients develop characteristic thickening of the earlobes, loss of eyebrows, and a leonine facies appearance, which means the facial features look rough and swollen. Unlike some other forms of leprosy, here there is no granuloma formation because the immune system shows a poor cell-mediated response. This happens due to an inappropriate Th2-skewed immune reaction, which fails to contain the Mycobacterium leprae effectively. There is no specific antibody to use as a marker in this form of leprosy. The best way to diagnose it is through a skin biopsy or smear, particularly the slit skin smear microscopy that reveals a high load of acid-fast bacilli, confirming the presence of the bacteria causing the disease. The combination of numerous symmetric numb lesions without granulomas is a key clue pointing to lepromatous leprosy. This patient's presentation of numerous symmetrical, flat, numb skin lesions, along with loss of eyebrows and thickened earlobes, is characteristic of lepromatous leprosy, which is the disseminated form of the disease. The biopsy showing sheets of foamy macrophages filled with acid-fast bacilli, but no granuloma formation, indicates a heavy bacterial load and a failure of the immune system to mount an effective cell-mediated response. This pattern reflects a Th2 predominant immune response, which is associated with weak cell-mediated immunity, allowing the bacteria to proliferate widely. In contrast, tuberculoid leprosy involves a strong Th1 response with granuloma formation and a much lower bacterial load. Thus, this patient's immune reaction is skewed toward Th2, leading to disseminated lesions and abundant bacteria. Infectious mononucleosis caused by Epstein-Barr virus typically presents with fever, swollen lymph nodes in the neck, sore throat, and an enlarged spleen. On a blood smear, you'll see atypical lymphocytes, which are actually activated CD8 positive T cells responding to infected B cells. It's important for patients to avoid contact sports to reduce the risk of spleen rupture. Also, ampicillin should be avoided because it often causes a rash in these patients. The classic combination of fever, sore throat, swollen posterior cervical lymph nodes, and atypical lymphocytes points strongly to EBV mono. For diagnoses, the heterophile antibody test, often called the monospot test, is the first choice, but if that's negative, EBV-specific serology can be done. This immune response is primarily driven by CD8 T cells, targeting the B cells infected by the virus. A college student with fever, sore throat, fatigue, swollen lymph nodes behind the neck, tonsillar exudates, and an enlarged spleen is showing classic signs of infectious mononucleosis caused by Epstein-Barr virus. On the peripheral blood smear, the atypical lymphocytes observed are actually activated CD8 positive cytotoxic T cells. These cells expand in response to infected B cells, which the virus targets. But the infected B cells themselves are not what you see as atypical lymphocytes. It's important to distinguish these from other cell types, like Reed-Sternberg cells, which appear in Hodgkin lymphoma rather than in mononucleosis. So in this condition, the immune response is dominated by these activated cytotoxic T cells fighting off the virus within the B cells. To identify autoimmune diseases, focus on the specific antibody or marker present and understand the underlying mechanism, which typically falls into one of the 4 hypersensitivity types. This combination helps pinpoint the exact diagnosis. For immunodeficiencies, consider when infections occur and what type of organism is causing them, as this narrows down the defect to B cell problems, which often present with bacterial infections in the sinopulmonary area. T cell defects, which usually lead to viral or fungal infections, or combined immunodeficiencies, which are severe and usually evident from birth. When dealing with infectious or immunodiagnostic diseases, match clues from serology or histology, like heterophile antibodies, IgM capture tests, protein electrophoresis spikes, or patterns of immune deposits in tissues, to the likely causative organism or associated malignancy. Keeping these patterns in mind will help you quickly connect clinical findings to diagnoses and perform better on your exam. Good luck!